next few slides, what I have pictures of what we normally do. So the left-hand picture is an endoscopy of a patient who's got cirrhosis of the liver, and he developed significant esophageal varices. As you can see, these kind of nodular channels. These columns are the esophageal varices, and if they bleed, they can bleed. They can bleed to death, and this is an emergency. So these patients, we optimize them very quickly, and then we do what we call an endoscopic banding ligation. Sometimes we do what we call a balloon tamponade, where the bleeding is quite severe. They can't see where the source of bleed is. You can actually stop it by putting a balloon tamponade to stop the bleeding temporarily as a bridging therapy, and then you go back again, and then you do definitive therapy through the endoscopy using banding techniques or other various techniques like glue technique or tips. So various different mechanisms where you can actually stop this bleeding, and it gives immense satisfaction that you see something is bleeding and then you stop it, the patient's blood pressure improves, pulse rate drops, and you see an immediate change in the patient's color, and from pale it becomes nice dusky, nice reddish color. So you see all these kind of differences when you're doing it, and it gives immense satisfaction that yes, you have done something good for the patient. Okay, so this is how it is done. You actually suck the varix, and then you put a band on it, endoscopic varicose ligation. So that's how it's done. So this is another thing which has been, particularly in Western countries like in UK and US, the bowel cancer screening program. In fact, from 2000 onwards, along with the liver diseases growing in number, one of the other reasons why there's a huge number of gastroenterology jobs which are coming up is because of the bowel cancer screening program. We know that these kind of polyps in the colonic polyps, which are adenomatous polyps, which if left alone, these are the ones which will turn into cancer through as you probably have heard about this, the abnormal gene pathway, APC gene pathway. So that's how they turn into abnormal cancer cells, okay? If you remove these polyps at an early stage, like as shown in this picture, using a simple colonoscopy and polypectomy, you eradicate the sequence of the cancer. So this has become a very successful, and there's a lot of bowel cancer screening programs which are run in the Western countries. In fact, anybody above 45 years, they mandatory will get offered for a colonoscopy, and everybody gets a colonoscopy above 45 years, just primarily to prevent. And this has been so successful that out of every 1 in 10 colonoscopies, we do pick up these polyps. And out of every 100, we're able to prevent a cancer. So this has been in terms of screening programs, along with the breast screening program, the mammograms, the prostate screening programs, the bowel cancer screening program has been very successful. And this is the reason why there's so many gastroenterology careers and jobs. And my friends, my colleagues who are my own classmates from MBBS, who are about 6 of them are gastroenterologists in US, and each one is earning, a good amount of handsome salary. I'm talking about close to 1 million a year, or at least 800,000 pounds to 1 million a year. So that's a good amount of salary they are able to draw, primarily by doing colonoscopies, not even advanced procedures, but primarily doing colonoscopies. They are still able to earn a lot of money. So if you're looking for a job security for a branch where you will definitely have hands-on experience, procedures, and at the same time, you will have a job security for the rest of your career. Certainly gastroenterology is one branch which will definitely give you that. And as I said, it's still evolving. So that definitely, puts it a better pace for the rest of your career. Okay, so another polyp which got removed, and then as you can see, we put some clips on it. So that's another way of actually removing the polyps. There's another one which we're seeing, and I think as we all know that the people are getting more and more obese, and particularly childhood obesity is growing in number. And the estimate says that about 25% of the children are obese these days, what we call a childhood obesity. And these are only going to grow in number. And as they become older into the adults, you can imagine the amount of problems that we are going to face from the obesity. There are various techniques which can help us in losing weight. Bariatric surgeries is one of them. There are different types of bariatric surgeries as well, like sleeve gastrectomy, switch operations, duodenal switch operation, Roux-en-Y operations. But another kind of techniques which have been evolving is which can be done without having any cut on the abdomen, or we call it a cut-free or a suture-free techniques called the balloon techniques, or where you actually pass a balloon into the stomach and you inflate this, the balloon, and then basically you reduce the volume of the stomach, and therefore you start losing weight. On an average, people lose about 20 to 25 kilos of weight with the balloon, intragastric balloon placements. And also another technique which have been coming up is endoscopic sleeve gastrectomies, where you actually suture the greater curve. So you basically make the sac much more smaller, so that you get your volume of the stomach reduces, your satiety reduces, or you get early satiety. So those are other ways of actually endoscopic techniques where you can actually do bariatric surgeries. Okay, so another picture which shows that the volume, we inflated up to about 700 ml. So it basically primarily occupies maybe about 3/4 of the stomach volume. So therefore it reduces the stomach capacity. Okay, another techniques which have come up very lately, or the last, probably I would say 10-15 years, is the spyglass cholangioscopy. Now, as the name says, it's quite exciting, spyglass, but basically what it means is whenever you have a large CBD stones, or if you have a stricture which we don't know whether it is a benign or malignant biliary strictures, with this neo-mesh technique where you can actually pass a scope inside another scope. So this is the mother scope and this is the baby scope. You pass this scope inside, and then the areas where we never used to imagine going in and seeing, we're able to visualize them with this camera. So you can, this is the bile duct, you can see there's a hilum. So there's a right duct, there's a left duct, and you can actually see if there's any malignancy. You can actually see the abnormal tissue. There's a normal tissue, and you can see this in abnormal tissue. So you can, and as you can see, this is all now benign picture, benign strictures, and these are abnormal disease strictures. So you'll be able to clearly differentiate. Previously, we used to really struggle understanding strictures. We're not able to see those strictures. So now we're able to go in, understand the pathology, and also differentiate. And also we can use narrowband imaging to get much more defined understanding about the stricture, or whether it's a malignant. If it is malignant, how severe, how significant the malignancy is. And this is another technique where you can actually, these large stones, previously we used to only do stent exchanges for these patients, but now we're able to break the stones and completely remove them with endoscope. Similarly, this a patient with hilar stricture, the what we done here, as you can see, we put a stent, a Y-shaped stent to release the jaundice. So, and you get an immense satisfaction whenever you see this jaundice. It's like delivering a baby. You get immediate satisfaction when you see the thick, dark bile flowing out of the stent after you place a stent. That gives immense satisfaction. Just look, we have saved somebody's life, and they will get better. Okay, that kind of satisfaction you get immensely with these kind of procedures. Similarly, another technique where you can actually remove or drain the bile is by doing this PTBD technique, where you actually put a wire over the transhepatic route, and you grab that wire, and then you leave it into the duodenum, and then over that you put a stent inside. Okay, another thing which I'm very excited about technique is the endoscopic ultrasound. I'm sure you know about ultrasound and you know about endoscopy. So if you combine both of them, that's the endoscopic ultrasound. So in other words, it's like an internal ultrasound. Okay. So this endoscope has got an ultrasound. This is an ultrasound probe. This is a transducer. As you can see, the white purplish, the pearl-shaped, creamy-shaped, that's a transducer. So with this, you can actually scan the structures, and you'll get a pictures like this, and you can see the different layers of the stomach wall here. Okay. So in this picture, you can see that there is a lump here. That lump is nothing but what we call in endoscopic ultrasound terminology, we call it as a hyperechoic structure. Straight away, so I can say that this is a lipoma or a fat, so don't need to worry about it. So previously, these kind of lumps, when you see in the stomach, we used to get worried whether is it a cancer, is it a pre-malignant condition? How are you going to see this? We'll have to open it up with the laparoscopy or laparotomy, see the stomach, get the biopsy, and then do it. But nowadays, with these kind of endoscopic ultrasound techniques, we're able to easily make a diagnosis saying, look, this is a lipoma. We don't need to worry about it. We don't need to take it out. You can simply ignore it. And similarly, you can also stage number of cancers and diseases. And not only that, you can take biopsies. For example, this is the pancreatic head of the pancreas. And if you see there's a mass there in the head of the pancreas, instead of doing a laparotomy and opening the stomach, just to get a diagnosis with a simple day case technique, you can, which takes only about 10-15 minutes. You scope this, you scan this area, and then you see the lump, and then you pass a needle through the stomach wall into the pancreas. You collect all the samples. You get good core biopsies, and that's it. You're done. You get a biopsy. So we're able to reach the areas, even including the mediastinum. For example, you got heart, and next to the heart, you have all the important structures, and you have mediastinal lymph nodes. So whether it's a sarcoidosis, lymphoma, tuberculosis, or is it Kikuchi syndrome, so many other diseases, we don't know unless we get a histology or a pathology. So with this simple technique of endoscopic ultrasound, we're able to scan these areas, these lymph nodes, and able to take a sample similar to one like this, and able to get a diagnosis. So the endoscopic ultrasound has helped us to reach the areas which were improbable areas, which were thought to be improbable areas in the past. Now we're able to deal with it very simply and very easily. Like, for example, so this is the same picture, pancreas. If there's a lump here, I'm able to simply pass a needle from here, take a sample, and then get out. Okay. I can also do a local regional staging, so I can clearly tell you that whether it is invading the vessels around the pancreas. So is it a resectable, non-resectable? So I can give you all that kind of information, an accurate local regional staging by using this endoscopic ultrasound techniques. Okay, so if somebody has got stones in the CBD, you're not able to pick it up in any other way. Endoscopic ultrasound is a beautiful way of demonstrating these pictures, the stones, and then you can do the further intervention as is needed. As you can see, this is a structure which has got a tumor in the head of the pancreas. You can see that's a portal vein, and you can see a clear whitish fat lane, which means I can say that this tumor is not invading the portal vein. You will not get this imaging on any other modalities, like you look at CT or a MRI scan. If you look at a 264 slicer, you may not get all this kind of detailed information. So you can make a huge difference in terms of planning, stratifying, staging your treatment for these patients as well. Okay, so this is a mediastinal structure. As you can see, this is the aortic arch, and you see there's a big mass around here, and this is the esophagus. So you can actually scan this area. You can sometimes go through the aorta and take a sample from that mass. So before, what they used to do is open the chest, do a sternotomy to get to this mass and get a diagnosis, to at least get a diagnosis. But nowadays, we don't need to do that. We can just simply pass the endoscopic ultrasound. Through this, you can scan. So not only endoscopy, we can visualize the lumen or the mucosa, but with this endoscopic ultrasound, you can visualize the structures outside the lumen, and we're able to get a diagnosis for these patients. Another one, which we saw, this is a lump. This patient was just an incidental finding. And I put an endoscopic ultrasound scope, and you can see simply there's a hyperechoic structure. So I can confidently say that this is just a lipoma. This is a non-malignant condition. We don't need to do any further surveillance or further follow-ups. We don't need to remove this lump at all. So I can simply reassure the patient just by one look at this with an endoscopic ultrasound. Okay, and another one, similar kind of a lump. When we did an endoscopic ultrasound, we picked up that this is a gist, or it is coming from the muscularis propria layer. So we lifted that lesion, and then we encoded it and then removed it with endoscopy. So this patient previously would have, in fact, this patient presented with a massive GI bleed, had a recurrent GI bleed, and came with a hemoglobin of 5. So we optimized him, looked at it, and we found that this is the area where he's bleeding from. And then I could remove that. And as you can see, the base is completely clean. There's no perforation. So I could remove this lump using the endoscopic ultrasound techniques. Okay, another one, pictures, as you can see here, the needle coming up into the mass and taking a biopsy. So you can also see that there's a lot of intrahepatic dilatation. You can see the kidneys, you can see the spleen, you can see the adrenal glands. So all these structures, you'll be able to see them very, very nicely. And this is a fluid collection around the pancreas, the pancreatic pseudocyst, and we're able to drain those collections. And even these days, when you're not able to do ERCPs because duodenal obstruction, you can put a needle through here into the bile duct, and then you can put a stent across it. So these are the newer techniques where previously we used to go for surgery. Nowadays, we're able to do it with the endoscopic techniques itself. And there's another one with patient comes with a varicose bleed and you picked up they got fundal varices. You can do gluing techniques using these catheters where you can actually stop the bleeding. I think I showed you this picture earlier. And this is another patient with multiple CBD stones, came with cholangitis, and we had to initially put a drain into his gallbladder to drain it. And you can see the bile duct is completely stacked with stones. So one after the other, we slowly removed all these stones. And this is the typical ERCP pictures. You see the bile duct and you see the pancreatogram, and this is the cholangiogram, and you can see the gallbladder full of stones. So again, a lot of different therapies, interventions that you can do. This is another new kid on the block, to be honest. The small bowel was always a very difficult area to reach. The endoscopy, you can reach up to the upper GI endoscopy, you can reach up to the D2 area, and with the colonoscopy, you can reach the whole colon. But the interim small bowel, which is about almost 6 to 7 meters, we're never used to reach that area very easily. But this newer technique of the power spiral enteroscope, which is a motorized power spiral enteroscope, you're able to pleat the intestines and you're able to completely go through the intestines and see all these structures. And we've done quite a few procedures, and it's trust me, it's so much satisfying that you pick up a reason where they're bleeding from and you stop it bleeding from. So these are the patients who we get from different places of India, from Northeast, North, a lot of places, and even international patients as well, where they did number of endoscopies before, they couldn't find the reason. Colonoscopy was done, they couldn't find a reason. And then we do this spiral enteroscope, you find the reason in the small bowel and you stop it bleeding. And that gives so much of satisfaction for us when we do these kind of techniques where it matters and it helps the patient immensely. Okay, so there's another one. You can see that in the stomach there's an antral ulcer. That's a pylorus there, and this is the antral ulcer, deep ulcer. And another procedure, another patient where he was actually having an active duodenal spurter, and we were able to stop it with the hemoclips. Okay, so various different techniques where you can actually, with least intervention, minimally invasive techniques, you're able to do the necessary intervention. And trust me, as I said, this is a procedure. This is a branch where we'll definitely will have plenty of jobs in the future. Okay, so thank you very much for listening. I'm happy to take any questions that you have. So we do run a Save the Liver Foundation program where we so far have done mass screening for hepatitis for lakhs of patients, and we're able to treat about 80,000 patients through our Save the Liver Foundation. I'm happy to take any questions on it, or you can search on the internet to find out more details about Save the Liver Foundation.